Okay, everyone, hope you're all well. Welcome to the Pregnenolone Masterclass 2.0. This is a updated and revised version of the Pregnenolone Masterclass that I recorded about 2 years ago. Most of what I said 2 years ago, I will stand by, but there are a few updates and changes that I'd like to make. But most importantly, I wanted to record it with better audio visual quality for you, just so that you can enjoy watching the content more. Now, as you can see from behind me, over here, I'm at my friend Ali Gilbert's studio in Florida. Big thank you to Ali for having me and allowing me to use her space to record this for you guys. Given that you'll be watching this on YouTube, you will have worked out by now that this is a free masterclass. I am very excited and passionate to be able to make this content available for free. This is going to be long. This is going to be detailed. I am literally going to cover everything I know and everything that you need to know about the hormone pregnenolone. This is a 5-part lecture. Part 5 is exclusively available for members of the TRT Academy. Parts 1 through 4 cover the vast majority of everything you need to know about pregnenolone. I am not holding out on key information. Part 5 is purely looking at case studies. So if you're a practitioner or you're an enthusiast and you want to see how this plays out in practice, there is an additional 20 to 30 minutes of content on this masterclass available exclusively for members of the TRT Academy. The Academy is $19 a month. You can sign up via the link below, but I can assure you that you will have more than enough information covered in this free masterclass. So we have got a lot to cover, so we're going to get straight into it. So this is, as I said, a 4-part series with a 5th bonus part available for the Academy. Part 1, we're going to be talking about the basics. Part 2, we're going to be talking about treatments. Part 3, we're going to talk about myths and theories. And part 4, we're going to be talking about practitioner questions. And that bonus part 5, as I said earlier, is the case studies. So pregnenolone, what is it? Why do we need to know what it is? So pregnenolone is the direct precursor to every sex hormone in the body. This cascade of sex hormones is called steroidogenesis, and it begins with cholesterol, which is metabolized by the enzyme CYP11A1 into pregnenolone, which is then converted into progesterone, DHEA, and then all the different metabolites downstream from there: testosterone, estrogen, and DHT. Very important part of the human body. When we look at what pregnenolone is when it enters the body, it's both pregnenolone and pregnenolone sulfate. This is important, and we are going to visit the distinction between these two hormones. Pregnenolone sulfate can also be referred to on labs as pregnenolone S. When we measure DHEA in the blood, we're typically 99% of the time measuring DHEA-S, which is DHEA sulfate. So I'm going to throw up an image of the steroidogenic cascade here. One thing that I am going to cover in this lecture is the term downstream and upstream hormones. It is very important to recognize and understand that this is a graph for illustrative purposes. These arrows do not literally represent things like rivers or ladders where the hormones will freely flow downstream. This is a graph, and the graph shows how precursors work, but I really want to emphasize that if you just pour hormones into the top of this graph, it doesn't flow down the cascade like people oversimplify it can. This is for illustrative purposes. Hormones do not flow through the body like water. I really want to emphasize that point. So we're going to look now at the distinction between pregnenolone and pregnenolone sulfate. So when we look at the roles of pregnenolone and pregnenolone sulfate in the body, you'll see that they have almost like a yin and yang component to them. And together they cover the holistic effect and benefits of pregnenolone. So regular pregnenolone is a negative allosteric modulator of the CB1 receptor. So the CB1 receptor is part of your body's endocannabinoid system, which is the endogenous system that both cannabis and then internal cannabinoids such as pregnenolone and anandamide bind to exert their effects. It is interesting that the body has receptors specifically for cannabinoids. So as a negative allosteric modulator of CB1, this is a fancy jargon term of saying that it turns down the receptor sensitivity. This is important when we come back to looking at the potential symptoms of having a pregnenolone deficiency relating to THC. It's also an agonist of the receptor called Pregnane X. Pregnane X is very important systemically in the body, but particularly in the liver, for activating detoxification pathways. It is also a weak allosteric modulator of the NDMA receptor. That's not MDMA, that's a different compound. NDMA, which is very important for managing and modulating excitotoxicity in the body. And it is also a sigma receptor agonist as well. Now, when we're looking at pregnenolone sulfate, again, it is a negative allosteric modulator. So again, it turns down the receptor sensitivity, but this time of GABA A. So it's very important that we look at hormones in balance, because then we also have progesterone and allopregnenolone, which are two metabolites which are positive allosteric modulators of this receptor. Pregnenolone sulfate and DHEA sulfate are both negative allosteric modulators. So together, when these hormones are all optimal, it brings these systems into balance. A lot of the time when we're looking at biohacking or pseudo hormone optimization, we're looking at cherry picking the things we want, and we want more dopamine and more GABA and more testosterone and less ABCD. Whereas in reality, what we want to do is optimize the body's systems so that the hormones work the way that they're supposed to in balance. Another really important role of pregnenolone sulfate is, again, it is also a weak positive allosteric modulator of the NDMA receptor, as well as a sigma receptor agonist, but it also modulates the glycine receptors as well. So this hormone has a variety of mechanisms for modulating neurotransmission. Virtually everything that we've spoken about here, bar a couple of things, are very important for neurological function. So pregnenolone and its metabolites, pregnenolone sulfate, allopregnenolone, DHEA sulfate, are often referred to as neurosteroids. This means that they are steroidal, they impact the function and they upregulate the function of neurons firing. They are very important for neurological function, but they are also very important for neurological protection as well. So, what does pregnenolone do subjectively? This is, I think, what most people are interested in. When you take the hormone, what is it going to do? What are you going to feel? What benefits are you going to notice? And I would argue, very importantly, if you haven't considered this already, what potential side effects could you run into if you take it when you don't need it, you take too much at a time, or most importantly, you're not working with a provider who understands optimizing the entire endocrine system. So in jacking your pregnenolone up with exogenous supplementation, you could be throwing your hormone system out of balance. So when we correct a deficiency, and this is referring to the benefits of pregnenolone, we're typically going to be looking for a significant reduction in anxiety. Now, I'm going to get this out of the way. Pregnenolone is not a panacea or a miracle cure for anxiety. You can have optimal pregnenolone levels and be an anxious wreck due to psychological issues. It is very, very important when we're looking at mental health that we look at both columns of biological factors and psychological factors. And I believe, and I have observed, that a lot of people in this space are trying to fix psychological issues with biological interventions. This doesn't work. When we're looking at fixing mental health from a biological standpoint, we are repairing the foundation so that the psychology can then heal or be healed through other interventions. But with that said, a low pregnenolone state neurologically will subjectively feel very anxiogenic. You kind of feel always on edge. I like the term cranked. I think cranked is a good term, because cranked to me means kind of like you've had too much coffee in a bad way. It's the uncomfortable overstimulation, not favorable stimulation. We also tend to notice a significant improvement in well-being. Now, well-being is a term that doesn't really mean anything. So I am very aware that this is a bit of a woo-woo and esoteric term. But when we look at an improvement in subjective well-being, this is something that people go, hey, I just feel better. I would argue that this is because it brings the brain and the body more into balance, like a thermostat, but it is also improving detoxification pathways and having significant anti-inflammatory effects. When you turn down brain noise and you bring more mental peace, you reduce stress in the body and you upregulate detoxification. I think it makes a lot of sense that the consciousness that is embodying this physical vessel is going to go, hey, I feel better. So elimination of brain fog, that's another one that comes up as well a lot. So when we're looking at low pregnenolone states, a lot of the time people have poor memory, poor cognitive function. And when you restore pregnenolone levels, people go, oh, I can think again. I can remember again. I have the correct verbal acuity and recall and working memory, all of these things that allow people to actually just function and fire properly and not feel like they're going through life in a cloud. We also tend to see enhanced senses. People will say that they notice colors are brighter, music sounds better, food smells better, tastes better, things like this. These are often things that happen when you resolve depression. And elimination of anhedonia. So anhedonia is not feeling pleasure from things that should feel good. So losing interest and engagement in hobbies. And people go, oh, I enjoy the things I used to enjoy. People also say they can focus better. And most importantly, they can also sleep better. this is something that I'll really re-emphasize in this 2.0 version of the lecture, is that pregnenolone is a phenomenal sleep aid when you correct an imbalance. If someone has optimal pregnenolone levels, yeah, they might sleep better, but then they're going to get the side effects we're going to discuss next. But it's very difficult to enter proper stages of REM and deep sleep due to the enhanced stress effects on the body when there's not enough pregnenolone and it's metabolized to buffer the effects. Now, what happens when you take too much pregnenolone? Because at this point, I'm sure a lot of people are going, great, going to jump on Amazon or Walmart if you're in the United States and just buy it over the counter. It's available over the counter in many countries. It's prescription in countries such as Australia. This is not trying to tell you to go out to take pregnenolone. What this is more emphasizing is that if there is a deficiency, then you're going to have these problematic negative symptoms. However, if you have optimal pregnenolone levels and you top your pregnenolone levels up with exogenous supplementation, you are going to move into a supraphysiological state of pregnenolone. I would argue, and other practitioners that I've discussed this at length with over the last couple of years have agreed, that it seems like the majority, if not almost all of these side effects, are caused by an overconversion to progesterone. When a man's progesterone goes too high, it has an anti-androgenic effect. Progesterone is extremely important for men, just like testosterone is extremely important for women. We're very sensitive to it. And because pregnenolone preferentially converts into progesterone, we can run into some anti-androgenic symptoms if we jack our progesterone up too high via pregnenolone supplementation. To summarize, it's basically anti-TRT. But the things that people typically report is fatigue. I call it a unquenchable thirst for taking a nap. Erectile dysfunction is a big one as well. The thing that guys will most commonly report, I call gummy worm dick. This is when you lose all sensitivity in the penis and it's simply an appendage for urinating. This is also very common with the anabolic steroid nandrolone. And what these two hormones have in common is that nandrolone is a synthetic non-bioidentical progestin. So again, it is likely exerting the same pathway in effect via the progesterone receptor. When guys get too much pregnenolone, they will often have an increase in anxiety and an increase in brain fog. My hypothesis for this is that when you have optimal pregnenolone levels, you then create a bottleneck and you end up with too much pregnenolone and pregnenolone sulfate relative to your progesterone and allopregnenolone as well. So it can create multiple systemic imbalances. And I think this is why some people at least, can get an increase in anxiety. Gynecomastia is also something that can pop up as well. Gynecomastia is not only caused by estrogen, it's caused by a combination of estrogen, progesterone, and prolactin. Some guys will also notice a reduction in muscle tone. It's not going to make you lose your gains, but it can make the muscles seem to hold less glycogen, and bloating and water retention. Over time, guys tend to notice that it will also add fat gain, especially around the less flattering areas, such as on the chest and on the hips. What is it actually doing objectively? Those are the subjective effects. What's it doing objectively? So it acts as a neurosteroid, an antioxidant, and a neuroprotectant. It modulates the production of neurotransmitters on its own, as well as via conversion to progesterone and DHEA and its sulfated form. This is a really important one that I'm going to come back to quite a few times and that I've touched on already. It antagonizes the effects of cortisol and adrenaline biologically. So we're not going to be reducing serum levels of these hormones. These hormones are also very important, although cortisol often gets a bad rap. Your cortisol goes to zero, you will drop dead and die. Cortisol is the thing that gets you up in the morning. It's the anti-inflammatory response to stress. We blame cortisol. It's like blaming the fire alarm for the fire. It is important, however, that cortisol's effects are buffered in the body. And when pregnenolone is low, the stress hormones have a more potent action on their receptors. And this can feel like, one, subjective anxiety, but two, it can also promote catabolism, fatigue, poor sleep, high stress state, not feeling very good cognitively over time. It also reduces prolactin. And over the last couple of years, I have seen massive drops in serum prolactin when we restore pregnenolone deficiencies. It will often cut in half. It increases progesterone and allopregnenolone primarily, as I mentioned previously, as well as DHEA slightly. So I'm going to address the question here now, which often comes up. Supplementing with pregnenolone will increase DHEA a bit, but it will not correct a DHEA deficiency. It's not a 50-50 metabolism to progesterone and DHEA. It seems like it is at least a 70% preference towards the progesterone pathway. So if both hormones are deficient, both hormones need to be optimized, but it is important to recognize at least that pregnenolone will increase DHEA levels somewhat. It also, in high doses, via its conversion to progesterone, acts as an androgen receptor antagonist. This is how it has anti androgenic effects, because not only do high levels of progesterone compete with androgens at the receptor, it also inhibits 5 alpha reductase. This is the primary enzyme that converts testosterone into DHT. And when we reduce DHT, we net a big loss in androgenic activity in the body. So we don't want too much progesterone. And a lot of the time when we're looking to optimize the end outcomes of pregnenolone treatment, I recommend that people also use progesterone as a marker to see if they have overshot or undershot the optimal dose. Essentially, you can take as much pregnenolone as you can tolerate the progesterone conversion that comes from it. An important point that I'll add in here as well, and this is something that has come up a lot over the last couple of years, is that it modulates the effects of all psychoactive compounds, everything from caffeine, benzodiazepines, alcohol, and very specifically THC, because it works on the CB1 receptor. So when you take anything that is an intoxicant, including caffeine, pregnenolone production is upregulated to protect your brain. So it regulates your neurons from becoming overexcited. So when you are low in pregnenolone, you tend to have a very sensitive response to just about everything. Why is pregnenolone important? So if we correct a pregnenolone deficiency, pregnenolone will rapidly resolve depressive and neurological symptoms. The response to people who need pregnenolone when they take it is why I have made this lecture. It's why I have made so much content on pregnenolone over the last 5 years, because I have had so many conversations with people where this hormone has literally saved their life. A deficiency, especially from head trauma, results in negative symptoms that are non-responsive or only partially responsive to other treatments. If you have a pregnenolone deficiency, nothing else will make you feel right except for correcting it. Some things may help a little bit, but you will always feel like something is wrong because your biology is off. So correcting pregnenolone deficiency is so important for people who have got a history of risk factors for low pregnenolone, which we're going to discuss shortly. And it's very, very, very important that everyone, especially people who have had age-related hormone decline, are checking their pregnenolone levels regularly. It offers a drastic improvement in quality of life. It is neuroprotective. It promotes longevity and health of neural tissues. So it is anti-dementia, anti-Alzheimer's, and it modulates the GABA and glutamate balance, as discussed previously, via the NMDA receptors. This is balancing how the neurons in your brain fire. It is a precursor to allopregnenolone, which has antidepressant, anti-anxiety, and anti-inflammatory effects. Allopregnenolone is very, very, very well studied for its effects on mental health. Allopregnenolone is like your brain's natural version of Valium. If you are deficient in this, you are not going to have a good time. Why do people become deficient in pregnenolone? The main one that I see is age. If you are old enough to have an age-related hormone decline in testosterone, thyroid, DHEA, growth hormone, melatonin, there is a good chance that you also have a decline in pregnenolone levels. I have met very few people past the age of 50 and no one past the age of 60 with optimal pregnenolone levels to date. So if you have primary hypogonadism, if your age has impacted your testosterone production and your testicles have less hormonal output, that is a good indicator that you may have other age-related hormone decline. The testicles do not carket before the rest of the hormone-secreting glands in your body do. They all decline together or relatively closely within a ballpark. However, in younger men, there's a few factors that can lead to a pregnenolone deficiency, and one that I did not discuss a couple of years ago. So the primary ones that we look at are head trauma, PTSD, multiple concussions, drug abuse, neurological disorders, as well as potentially psychiatric medication use and withdrawal. Now, if anyone is using psychiatric medication and they're concerned about the pregnenolone levels, you need to talk to your psychiatrist and your prescribing doctor. This is not an instruction to stop taking any medications. When we're looking at who is most impacted by head trauma, NFL is just crazy. Coming from Australia and working with brain injuries, I watched NFL the other day, it blew my mind. So NFL players are a big one. Martial artists, anyone who's been knocked out repeatedly or who has ended up in hospital from a concussion, there is a chance that you have got declined pregnenolone levels from this. Dr. Mark Gordon has made fantastic content around this and raised fantastic awareness for this. So a big thank you to him for bringing this into the forefront. And I would argue that this has been a huge, huge catalyst in helping, I would argue, thousands of people restore their quality of life after head injury. The one that I will add in here, which I did not include a couple of years ago, is anabolic steroid abuse, particularly prior to the age of 25, which is when the brain finishes developing, and particularly for men who have abused supraphysiological doses of nandrolone and trenbolone. I am not sure, I have some theories as to why these steroids, which are both the 19-nor steroids, tend to dysregulate not just the gonadal axis, but the thyroid and adrenal axis. This is something that I have observed. This is something that other colleagues have observed as well. And if you are coming from a background of anabolic steroid use and you've restored your testosterone levels with TRT, but you still feel like something is off, if this is a part of your background, I strongly recommend checking your pregnenolone levels. So how is it tested and how is it treated? This is getting into the meat and potatoes of the lecture. So one of the challenges that we have working in clinics or for doctors and practitioners working with pregnenolone is that the testing for it is really inaccurate. It is very difficult to measure a serum level of a hormone which is primarily manufactured in the mitochondria. Pregnenolone does not get made in one area of the body and then circulate like testosterone does. It is a locally produced hormone. This makes it very difficult to measure in the blood. When you are taking it exogenously, meaning supplementing with it, the blood results become a hell of a lot more accurate because now we are measuring circulating levels. But measuring endogenous, meaning internal levels of pregnenolone, is subject to massive fluctuations. One thing that I will add in here from the last 2 years of experience, which it is covered in this lecture, but I would like to emphasize this point. A undetectable pregnenolone level, in my experience, is an indisputable diagnosis of requiring pregnenolone supplementation. So if pregnenolone comes in undetectable, which is typically less than 10, this means that that individual has a pregnenolone deficiency. If it is detectable, it can fluctuate a lot day to day, and I do recommend getting multiple lab draws before initiating pregnenolone supplementation. Another thing that is difficult is that you can't check pregnenolone in every country. You can't check it in a lot of countries in Europe. Some countries will only check regular pregnenolone and not the sulfated form, which has a longer half-life, which is more accurate. In Australia, it's not available at all. And I will be talking about some workarounds for that a bit later in the session. If pregnenolone can't be tested, a good way of indicating that it may be deficient is when both progesterone and DHEA are low. And if we come back to the steroidogenic cascade here, as you can see, DHEA and progesterone are both direct metabolites. So if someone has low pregnenolone symptoms and they have a deficiency of both the downstream metabolites, it is far from a slam dunk that they definitely have a pregnenolone deficiency, but it absolutely warrants a trial. Cortisol can also be elevated in a chronic stress state, irrespective of pregnenolone levels. And I do find that chronic stress, whether it's from physical pain, psychological circumstances, difficult chapters in life, poor metabolic health, I mean, the list goes on, these will absolutely mimic a pregnenolone deficiency. So it is very important to have someone look at this for you, outsource this diagnosis. Don't try to make it yourself. I will always recommend a trial of low-dose pregnenolone in the presence of optimal blood work if there are both symptoms and a probable root cause. So what do I mean by this? If someone has got severe pregnenolone deficiency and they've got a history of head trauma, even if the blood work comes back in optimal, I believe, due to how inaccurate the blood work can be, that in these circumstances, it is worth a trial of a low dose of pregnenolone, not a replacement dose, to see if it is beneficial and well tolerated. We're going to discuss dosing shortly. Pregnenolone can be taken 1 or 2 times a day by oral, topical, or sublingual troche. Most people, and this is one of the tricky things about pregnenolone, because I would say 60 to 70% being most, not 95 to 99%, most people will find pregnenolone relaxing due to its conversion to progesterone and allopregnenolone, which has tranquilizing-like effects. However, some people will find it stimulating and will prefer morning dosing. Personally, I recommend split dosing for anything greater than 50 milligrams per dose. The reason for this is that 25 to 50 milligrams in most studies tends to be the replenishment dose for a deficiency. And if someone does benefit from higher levels than this, I do recommend either splitting it up, or if it's taken once in the morning or once at night, it is taken via a sustained release micronized capsule. When we're looking at these symptoms of a deficiency, insomnia, anxiety, a stutter, unable to tolerate optimal doses of testosterone, brain fog, high sensitivity to stress, memory problems, low resilience, anhedonia, and potentially mild schizophrenic symptoms, it's very important that we start to turn the lens on what the pregnenolone levels are in the body. One thing that I have highlighted here, and I will highlight again today, is this inability to tolerate the optimal dose of testosterone. And I'll give an example. A gentleman will say, well, 150 milligrams of testosterone doesn't fix my negative symptoms, but 175 milligrams resolves my negative symptoms, but now they can't sleep and they're overstimulated. A lot of the time, these men will try to find this Goldilocks zone in between in this 25 milligram range. However, if people have a stark separation between symptom resolution and side effects with a small amount of testosterone, in my experience, this is more of an indicator that they need to be able to tolerate the optimal dose rather than find this middle Goldilocks zone when that higher optimal dose is well within physiological limits. Pregnenolone comes in a variety of forms. I believe it can be injected. I have never worked with injectable pregnenolone, and given that it is not bound to an ester when it's injected, I'm not going to be recommending that. Oral is by far the most common application of pregnenolone, followed by troches or topical. Now, I prefer to work with oral. The reason why I prefer to work with oral is it's more accessible and there is more literature on oral pregnenolone, and it is simply more accessible for the vast, vast majority of people, especially in pharmaceutical form. Sublingual pregnenolone and topical pregnenolone are arguably, at least mechanistically, advantageous due to increased presence of either the sulfatase enzyme via sublingual or 5-alpha reductase via topical. However, I have found that when someone actually receives proper hormone optimization, proper diet and lifestyle interventions, and uses a high quality micronized oral pregnenolone supplement, that they are able to receive all the benefits and use a simple and effective version. Topical also creates more issues in terms of the base of the cream, as well as potentially transference, absorbency. There can be a lot of issues for this in terms of getting the dose dialed in. So I recommend sticking to pharmaceutical grade oral compounded pregnenolone. I prefer micronized. And since writing this lecture, originally, I have stated that micronized is a preference, but non-micronized is okay. I will repeat that. However, I will really strongly emphasize that micronized should be the preference, and only in extreme circumstances when that is not available, and I'm not talking about saving $10 a bottle, when micronized is absolutely not available, then non-micronized is okay. The reason why we want oral hormones to be micronized is they skip the first pass metabolism in the liver and are absorbed gradually in the gut. What will make this even better, however, is if the micronized hormone is in a sustained release matrix. This allows the half-life to be even more elongated, kind of like attaching a ester to an injectable form of testosterone, and this allows for stability and optimized levels 24/7. The most significant troubleshooting protocol for all hormone supplementation is to stabilize levels and increase dosing frequency. So being able to stabilize and optimize the metabolism of the hormone is a game changer in not only receiving the therapeutic benefits that we're looking to achieve, but also to avoid the potential side effects discussed previously. Now, if you're looking for a over-the-counter micronized product, the brands that I have found which make this are BioVia, Douglas Labs, and Pure Encapsulations. There are likely more that I am not aware of, but I strongly recommend getting it compounded from the pharmacy under prescription of a practitioner who knows how to work with pregnenolone. However, I do recognize that not everyone watching this will have access to a practitioner of the sort. So, dosing. When it comes to dosing, the oral micronized and sublingual dosing yields similar results in blood tests, milligram per milligram. And I have found that micronized, while it will result in a similar blood serum level, tends to result in better outcomes subjectively, as well as reduced side effects. In terms of starting with someone who has got an identified pregnenolone deficiency, I like to start with 25 to 50 milligrams once a day, working up to most of the time 50 to 100 milligrams, and in some circumstances, all the way up to 200 milligrams. Some people just don't seem to metabolize it very well. If someone is looking to do a trial of low dose pregnenolone, I tend to recommend starting with 5 to 10 milligrams at the most to see if it's well tolerated before moving into these physiological replenishment doses. Pregnenolone has often been studied in very high doses. It has been studied in doses up to 800 milligrams for arthritis, and a lot of the studies on oral pregnenolone are in very high doses of 400 to 800 milligrams. I don't really recommend this kind of dosing, but I will say that people with intractable pain and chronic injuries can often benefit from higher levels of pregnenolone, but I find this tends to max out at about 200 milligrams for most people. Are there exceptions to the rule? Absolutely. Do exceptions disprove the rule? Absolutely not. So, in terms of levels that we're looking to achieve, I'm going to be talking about pregnenolone in nanograms per deciliter. The vast majority of pregnenolone testing all over the world is done in nanograms per deciliter. I have seen some labs do it in different units, but it is simply a matter of moving the decimal place. It's not something like testosterone, which is tested in 5 or 6 different units all over the world. It tends to be in nanograms per deciliter, and if it's not, it's easy to convert by moving the decimal place. The reference range for pregnenolone will vary lab to lab drastically. A common reference range, and I would argue a correct reference range, is 30 to 150 nanograms per deciliter. A lot of the time, it's simply like a less than 150 nanogram per deciliter. I have seen websites such as Life Extension promote that pregnenolone should be optimized to levels of 125 to 175 nanograms per deciliter. I do not disagree with this. However, I have seen many men do fantastically well with pregnenolone levels under 100. In terms of a deficiency, at what level should someone look at potentially doing a trial of pregnenolone? If pregnenolone is under 10, which usually will come back as less than 10, meaning it can't be detected, this is when I would absolutely recommend a physiological trial dose replacement. If someone has levels less than 50 nanograms per deciliter on multiple consecutive blood tests, this can but does not always indicate that that person has a pregnenolone deficiency. So, at what number should someone be looking at potentially doing a trial of this hormone? 50 is not a 100%. If it's 51 and above, you're fine. And if it's 49 and below, you've got a problem. But 50 is about the level, give or take, that I find that deficiency symptoms can start to occur. When we're looking at optimizing pregnenolone lab work, and again, it's much more about symptoms than it is about levels because the levels are not particularly accurate. It's important to recognize, are we looking at a 12-hour trough or are we looking at a 24-hour trough? Or if they take it in the morning, are we looking at a 2 to 5 hour peak? This will drastically impact the number that we're looking to optimize for because pregnenolone sulfate, which is the longest acting version of pregnenolone in the body, has a half-life of similar to DHEA sulfate, about 24 hours. So if someone is measuring a 12-hour trough, which is the most common for people who take a single dose before bed, I recommend aiming for a level of about 75 to 150. And if we're looking at a 24-hour trough, I don't mind the levels being a little bit lower on the bloods because it is going to be peaking higher throughout the day. 50 to 100 nanograms per deciliter tends to be the optimal set point for most people, but there are definitely people who fall outside of those ranges. This is simply a ballpark. Symptoms are number one. This is purely giving some loose guideposts so that people can wrap their head around the concept. It's really important, as I said before, that we do not increase progesterone to a supraphysiological level. Most men will start to get anti-androgenic symptoms when their progesterone levels go past about a 5 nanomole per liter if they have optimized testosterone levels. If they don't have optimized testosterone levels, most men do best with a progesterone level between 1 and 3 nanomole per liter in my experience. Now, I have worked with men who do benefit from their progesterone levels going as high as 8, 9, or even 10 nanomole per liter with pregnenolone supplementation. But again, I would argue that these men are exceptions to the rule and do not disprove the rule. So I'd like to go through some myths now. And I've covered these myths since this lecture in my book, Beyond TRT, which you can pick up in the description for 29 Australian dollars. I cover all the most common myths about pregnenolone, DHEA, thyroid, estrogen, fertility, and HCG in that book. But I would like to delve a little bit deeper into them here, as people often have a lot of questions. And that book is a very simplified handbook on these hormones. I highly recommend picking it up if you're looking for something that you can refer back to. So, the most common myth that I see surrounding pregnenolone is that pregnenolone is quote unquote shut down by TRT. And if, again, we come back to this steroidogenic cascade here, the idea is that if you create a negative feedback between the testosterone production and the hypothalamus, which is what signals the pituitary to secrete hormones which stimulate the gonads, that because you have done that in the gonads, that you have then done that systemically throughout the body. This is objectively untrue. This is a misunderstanding of very basic science. The literature which supports this misunderstanding of biology is based on the fact that when you use testosterone, the intratesticular levels of pregnenolone, progesterone, and DHEA are drastically reduced because the testicles go offline. You are fulfilling the end result of that gland's function via exogenous supplementation, and therefore not only is less of the precursors required locally in the gonads, but this doesn't extend to the rest of the body's hormonal cascade. It doesn't dysregulate the connection between the hypothalamus, pituitary, adrenals, and thyroid unless you are taking supraphysiological doses of non-bioidentical anabolic steroids. So while pregnenolone is produced in other tissues in the testicles, CYP11A1 is induced by a luteinizing hormone. So again, if we come back to this graph, the connection between the cholesterol and the pregnenolone is via CYP11A1. This enzyme is induced, meaning it is stimulated by luteinizing hormone. Luteinizing hormone goes to zero in the testicles and in the brain and systemically in the body when you go on TRT. However, luteinizing hormone is not the only thing that stimulates CYP11A1 production. If this theory was true, everyone, bar the few outliers, would have a pregnenolone deficiency on TRT of all ages, all shapes and sizes, and that also means that everyone would benefit from pregnenolone supplementation and would not receive side effects. This is not how the industry works. Ask any practitioner who is informed with pregnenolone, and they will tell you that not every man on TRT requires pregnenolone supplementation. This is not correct. So the tricky thing here that can complicate people's N equals one, meaning their individual interpretation of this information, is that they'll go, oh, well, when I went on TRT, my pregnenolone levels were low. In my experience, this is due to the fact that pregnenolone levels were low to begin with. They just weren't checked. If pregnenolone levels were checked prior to TRT, we would see that there may be a non-significant drop in serum levels that wouldn't really fall outside natural fluctuation anyway. But I have never to date, and I said this 5 years ago, I said this 2 years ago, and I'm going to say it again today, I have never in my entire career seen a TRT-induced pregnenolone deficiency. Never seen it. So there are theories that less pregnenolone is needed, as I said previously, when the end result of steroidogenesis is fulfilled via TRT. And other theories say that pregnenolone is less bioavailable in the absence of luteinizing hormone's effect on steroidogenic acute regulatory protein 2, which is abbreviated to STAR. I have not found this to be true in practice. People have all kinds of theories on the internet, but most of them are based on a misunderstanding of mechanistic theory. And what we see in practice is the most important. You can have a million theories about how the sky is green, but if you never go outside and see that it's blue, those theories are redundant. The second thing tying into this is that everyone can benefit from pregnenolone. This is a common myth that I see when people cherry pick the benefits, because when you look at the benefits of pregnenolone, they sound absolutely great. And who wouldn't want more of the benefits that pregnenolone provides? The problem, though, as we've discussed already regarding progesterone conversion, is that taking too much pregnenolone or taking pregnenolone when it's not needed because the body is optimally regulating its own production can cause an imbalance in the anxiogenic and anxiolytic neurosteroids, meaning the stimulatory and calming neurosteroids, as well as supraphysiological levels of progesterone, which can have unfavorable anti-androgenic effects. One of the biggest challenges that people have in HRT is a misunderstanding of the far-reaching effects of every hormone that we take. We can't just go, I want more libido, so I'm going to take more testosterone. I want to be more masculine, so I want to take more DHT. I want better sexual sensitivity, so I'm going to take more DHEA. I want to sleep better at night, so I'm going to take more pregnenolone. These things do more than just the handful of cherry-picked benefits that you're looking at, and they will only confer the benefits in the context of correcting a deficiency. So while it is important to understand that pregnenolone has all these fantastic benefits, it does not mean that more is better past an optimal set point due to how fragile and interconnected the body's endocrine system is. So the next myth that I would like to cover is that, quote, if I feel benefits from taking pregnenolone, this means that I need it. This is where it gets very complicated when people start to go on YouTube, go on forums, and start taking hormones as if they're vitamin supplements. So, because pregnenolone has many positive effects as well as its other metabolic effects through the conversion pathways that we've discussed before, many people find that when they take pregnenolone, they get this really nice anti-stress, anti-inflammatory, relaxing effect. This is great. The problem is that with repeated dosing, if it's not required, is that many men will then find that the symptoms such as gummy worm dick, insurmountable fatigue, increased anxiety, sometimes even worse sleep quality or constantly needing to nap, these symptoms will start to set in later. So again, men will try to, in the absence of proper hormone optimization, supervision, and testing, will try to find this sweet spot of what dose do I need to get the benefits without the side effects. In my experience, there are so many men who are chronically stressed due to poor diet, poor sleep, too much alcohol consumption, chronic pain, psychological and circumstantial stresses that they'll be reaching for hormones such as this to try to fix the effects of external stresses. But if they have optimal pregnenolone levels to begin with, increasing pregnenolone levels long term via supplementation will confer both benefits and side effects. I would argue that pregnenolone is only tolerated and only beneficial when it doesn't produce any side effects. Side effects from pregnenolone are an indicator that you have got the dose wrong, or if you're working with a practitioner who understands getting dosing correct, it means that it is not needed and you could even be significantly better off without. The next one I'd like to cover, which I've covered quite extensively in the Beyond TRT ebook, as well as the lecture, is that HCG increases pregnenolone. And again, I'm going to keep referring back to the steroidogenic cascade. The idea is that you firstly believe that pregnenolone will shut down all the upstream hormones. Again, this is a graph, not a literal river that hormones flow down. The idea is that if you restore luteinizing hormone function via using a mimetic, which is HCG, that you will then reactivate the pregnenolone pathway. There's a couple of problems with this theory, which in practice just doesn't turn out to be true anyway, but I would like to break down why that is. One, there are many men who have pregnenolone deficiencies despite optimal luteinizing hormone levels. And as I said, I have never seen a reduction in luteinizing hormone be the catalyst that induces a pregnenolone deficiency. It is head trauma, it is anabolic steroid abuse, or it is aging. Now, if we put HCG into a male who is on TRT and we restore the steroidogenic cascade, we will be increasing testicular production of both pregnenolone and DHEA, but this is not enough to confer a resolution of a deficiency because a deficiency in pregnenolone is systemic. It is not related primarily to the function of the gonads. So while HCG does increase some pregnenolone activity mechanistically, via the activation of CYP11A1 via luteinizing hormone, it does not resolve a deficiency. So there are studies which, as I said, have highlighted how this theory works. And as I said before, and I'll say it again today, I have never to this date seen HCG used in therapeutic doses, which is typically about 1,000 IU or less in divided doses over the course of a week on TRT, restore a pregnenolone deficiency. Never seen it. Another myth, and this is the last myth that I would like to cover today, is that a pregnenolone deficiency cannot be resolved naturally. Now, if you've got age-related hormone decline or head trauma, then you're most likely going to be looking at supplementation. But I have seen plenty of men have widespread hormone deficiencies due to their diet, as well as the use of statin medication and cholesterol inhibiting medications such as ezetimibe. What we need to understand from this steroidogenic cascade is that cholesterol and CYP11A1, which has the precursor of vitamin A, is very important for endocrine function. So whether people like it or not, cholesterol is an essential nutrient for hormone production. Your liver can make enough cholesterol to survive. It is a backup survival mechanism. It is not enough to thrive. So men need to be taking in, and women, optimal amounts of both cholesterol and bioavailable vitamin A in the form of retinol via the diet. This is found in red meat. This is found in egg yolks. This is found in dairy. This is found in high quality animal foods. I have seen many men optimize their pregnenolone, DHEA, and thyroid function by increasing or reintroducing red meat and whole eggs into the diet. I'm now going to go into part 4 of today's lecture, which are questions that I have often received from practitioners or that practitioners I think would benefit from knowing. So, question number 1, does pregnenolone need to be compounded from a pharmacy? The answer is no, it doesn't need to be, but it's beneficial if it is. One, we know that that capsule contains what it's supposed to contain. A lot of over-the-counter supplements don't have in them what they're supposed to. Some brands are better than others. What is most important is that it is micronized. And as I said before, the brands which make micronized pregnenolone, Pure Encapsulations, Douglas Labs, and BioVia are 3 that I know of. There may be more. But when you get it from a pharmacy, you can guarantee exactly what you're getting. And ideally, you can also put it into a sustained release matrix. But at minimum, we want it to be micronized and we want it to be pharmaceutical grade. So does it need to be compounded? Technically, no, but it's absolutely advantageous if it can be. Again, should everyone on HRT optimize pregnenolone levels? No. If men have optimal natural pregnenolone levels to begin with, in my experience, it is best left alone. As men get older, the amount of men with optimal natural pregnenolone levels becomes far rarer. So if a man has age-related hormone decline, then that's when the argument could be made that every man with age-related hormone decline should optimize testosterone. But it seems the factors leading to younger men having things like subclinical hypothyroidism, early onset hypogonadism, or even just a lack of proper androgenic function in their 20s and 30s, even when they're living well, whatever is impacting this, the endocrine disruption from the environment, doesn't seem to be negatively impacting pregnenolone and DHEA production in my experience. So unless younger men have head trauma or a history leading to potential pregnenolone deficiencies, I would argue that they should have their pregnenolone levels left alone. But when in doubt, run a blood test. The solution to this question is test, not guess. The solution to a lot of things with HRT or health in general is test, not guess. And that is a quote from Chris Kresser. Next question from practitioners. Should patients trial pregnenolone on TRT if levels are not in the upper quartile of the reference range? My answer to this is not straightforward. This is not a cop-out, but it's not straightforward. It depends. And it depends on the symptoms. Pregnenolone can be trialed for a short-term period. And I believe that when you are trialing a medication, it makes the most sense to use the minimal effective dose to create an observable subjective response to determine if it is well tolerated. There is no identified in any research negative feedback from pregnenolone supplementation, meaning that pregnenolone can be trialed and withdrawn and it will not impact endogenous production like TRT does. This is great news. So while 25 milligram doses, as I said before, is a good starting dose to correct a deficiency, a 5 to 10 milligram trial dose is going to be a better option because if it's not tolerated, it's going to confer less severe negative side effects that will resolve faster. Another thing I'm going to touch on here, and I did touch on this a couple of years ago, and I'm going to double down on this, is that while some men may benefit long-term from 5 to 10 milligrams of pregnenolone, in my experience, the vast majority benefit from more. And in my experience, if men are not able to benefit and tolerate about 25 milligrams and up a day of pregnenolone, it means they don't have a deficiency. I think that men can benefit from 5 to 10 milligrams of pregnenolone subjectively who don't have a deficiency and also get side effects that they can potentially then manage via other medications. But I don't think this is an optimal way to look at it long term. If men need pregnenolone, they tend to need 25 to 50 milligrams and up. I have seen very few men who needed pregnenolone benefit from only doses under 10 milligrams. The trade-off with this, however, if you are going to use a lower dose, is that side effects are going to be harder to detect. So there is a bit of a trade-off there. Again, what's the most optimal time to measure serum levels of pregnenolone? In my experience with all hormones, other than testosterone injections, I like to measure the peak. It's difficult to measure the peak if people are taking pregnenolone before bed. So if someone's taking pregnenolone before bed, I like to see about a 12-hour trough. If they're taking it in the morning, I'd like to see the peak. A 24-hour trough can be used. I just find that it's not as useful. The most important thing, though, is we know what we're looking at. And when we're dealing with hormones with a short half life, oral hormones, the difference between a 4-hour peak and a 24-hour trough is massive, and it moves the target. So it's important we know what we're looking at. Different practitioners will have different preferences, just like with thyroid, and it's totally fine. So if a practitioner says, I prefer to measure a trough, I prefer to measure a peak, that's totally fine. I don't think there's a right and wrong way to do this, but from my experience, I prefer to measure the peak. I've just found that that is more useful. For me personally, working with HRT, I prefer to measure all blood work fasted first thing in the morning with oral hormones taken somewhere between 1 to 3 hours prior. That's my preference. I've seen other providers prefer like a 4 to 6 hour steady state level. Totally fine too. Whatever is the preference of whoever is monitoring the blood work. The next one, what is the most common dose of pregnenolone? I'd say about 50 milligrams is probably the most common, with about an equal distribution after that of 25 milligrams and 100 milligrams. I found that it's rarer for men to need more than 100 milligrams of pregnenolone, but they sometimes do. And as I said previously, it's very rare for men to need pregnenolone, but need less than 25 milligrams. So on average, I'd say 50, but there's a decent amount of guys who benefit from 100 and a decent amount of guys who only benefit from 25. So 50 is the most common. Unfortunately, when it comes to over-the-counter supplements, the majority of them are dosed at 100 milligrams, which for a lot of people will be perfect, but for many others, it will be too much. How quickly do people respond to pregnenolone treatment? This is a great question. So many reports that we receive anecdotally is that they feel a subjective positive benefit within 30 to 60 minutes of swallowing the capsule and profound benefits within the first 72 hours of consistent dosing. In the literature for both pregnenolone and DHEA, we see benefits clinically within the first 3 weeks. Now, while serum levels build very, very quickly, I mean, we could measure a steady state level after 5 days. The saturation effect of pregnenolone, the prolonged exposure to optimized levels, is what is going to yield the long term benefit when it comes to treatment outcomes. So while the acute benefits are great and they're really great to see, from a clinical standpoint, what we really want to see is how is this individual doing, both subjectively and in terms of their blood work, after 8 to 12 weeks. So I'm a big believer in titrating pregnenolone gradually over time, just like with testosterone and other forms of hormone replacement therapy. I think start low, go slow is a good way to look at things. Going from 0 to a beneficial dose and then titrating up, I believe is much better tolerated and more beneficial and produces less risk than shooting straight for the moon. But everyone has a different way of doing things. As the late Dr. John Chrysler said, there is an art and a science to men's hormone replacement therapy. And I believe this statement has aged like wine, and it becomes more and more true every year that I work in this field. How often should pregnenolone be taken? Should it be taken in the morning or at night? And as I said previously, most do better taking at night, but a decent minority actually respond better to AM dosing. I'm a fan of split dosing. Given that pregnenolone should not be acutely overly stimulating or acutely oversedating, I think it's a great hormone to dose AM and PM. When I'm working with clients who have pregnenolone, DHEA, thyroid, melatonin included in their protocol, I like to compound the pregnenolone, DHEA, and thyroid in the morning, and then pregnenolone and melatonin in the evening. Some men also do well split dosing DHEA, but I find that more men do better with once daily dosing of DHEA because this more closely mimics the body's natural circadian rhythm. As I said previously, I think about 70 to 80% of men do better just taking it at night, and about 20 to 30% do better taking it in the morning. This is a pretty divided outcome, though. A lot of the time when we're looking at outliers, we're looking at a 1 or 2%. So this is where practitioners can find it tricky to give patients advice on what to do. I tend to recommend people trial taking it at night, but take it on like a Friday or a Saturday night where if it does keep you up and you don't sleep properly and you need to move the dose to the morning, it's not going to affect your work Monday through Friday. So how often should pregnenolone levels be measured and titrated? My argument for this is every 8 to 12 weeks. Now, you could measure levels after 4 weeks and have a clinically relevant level to make a titration from. But again, I am more interested in seeing what the long-term subjective outcomes are because there is a very large range that levels can fall into with hormone replacement therapy dosing. So I recommend finding a dose that works for the client or the patient and giving it 8 to 12 weeks before adjusting in increments of 25 to 50 milligrams, pending their response. Does someone take pregnenolone for life, or is it a short period treatment? And my answer for this is that it kind of depends. And it depends on whether the root cause of the deficiency can be resolved. If someone has suffered from a TBI or age related hormone decline, we're going to be looking at optimizing pregnenolone levels for life. But again, if someone takes it for a year, 5 years, 10 years, and stops taking it, their levels are not going to be damaged from the exogenous supplementation. They're simply going to revert back to where they would have been if exogenous supplementation had never taken place. This may be a little bit lower, though, however, if it has been a 10-year period, purely to account for age related hormone decline. In my experience, if someone has a pregnenolone deficiency and they correct it, they are not going to want to stop taking the hormone and it's not going to be an issue. Will pregnenolone levels be suppressed, and is there a withdrawal when ceasing supplementation? And the answer to this, as previously stated, is no. Will there be a withdrawal after ceasing supplementation? We do see this. And the reason why we do see this is that not only are you going to revert back to your deficient circulating levels, but your body was used to receiving optimal receptor saturation. So there can definitely be a rebound enhancement effect of the negative symptoms. If you have a pregnenolone deficiency and you correct it, I strongly recommend that you continue to take the supplement. I don't see any benefit to stopping pregnenolone supplementation in the case of a deficiency. Dose may need to be titrated, but if you found the thing that fixes your problem, I don't recommend that you stop fixing it. It's not a good idea, especially if you want to feel better. So, is pregnenolone contraindicated with any other medications or conditions? So, pregnenolone reduces the effectiveness of benzodiazepines and psychoactive medications and should be monitored closely with any psychiatric medication. So, pregnenolone is neuroprotective, meaning that anything that's exerting a psychoactive effect may have its effect lessened. This, I would argue, is a positive thing. However, if someone is dependent on psychiatric medications for mood disorders, the dosing may need to be titrated to allow for a reduced effect. Typically, patients with a pregnenolone deficiency will be hypersensitive, and then they may revert to requiring a regular dose of the psychiatric medications that they're on. However, a lot of the time, but not all of the time, the negative psychiatric symptoms may have been coming from, or at least be contributed to, by the pregnenolone deficiency. What does a typical pregnenolone protocol look like? Typically, we're looking at 25 to 50 milligrams 1 to 2 times a day on average. Plenty of guys take 100 milligrams once a day, but that's probably the most common thing that I see. Pregnenolone can be taken on an empty stomach or with a meal. Doesn't matter. Doesn't have to be overcomplicated. And if people miss their pregnenolone supplementation, I don't recommend doubling it up at the next dose. Simply revert back to your regular schedule. You don't need to make up for the dose that you have missed. Can pregnenolone be used to treat adrenal fatigue? I'm not going to go too into this because I've covered this in Beyond TRT, but adrenal fatigue is not a real medical condition. It is a pseudo-diagnosis of symptoms, and it is often a pseudo-diagnosis for hypothyroidism presented in a subclinical fashion. If you look at the symptoms of adrenal fatigue and look at the symptoms of hypothyroidism, you will be looking at a list of the same words. So adrenal fatigue is not real. Adrenal fatigue is symptoms. Your adrenals do not fatigue after stress. If they did, the human would not be a very resilient organism. So the important thing to look at here, though, is that a pregnenolone deficiency will increase chronic stress, and it will increase the subjective and objective deleterious catabolic effects of chronic exposure to stress hormones. So a pregnenolone deficiency can absolutely contribute to the symptomology of the complex that people get labeled with as adrenal fatigue, but it is very rare that in and of itself it will cure these symptoms. It is often required that other hormones are optimized as well. This will conclude the TRT Pregnenolone 2.0 Masterclass. Thank you all very much for sticking through to the end. I hope you found this valuable. I am now going to go on and record the case study examples in the TRT Academy for the bonus content. So if you would like to see some examples of how these cases can present in a clinic and how treatment is best optimized, feel free to join the TRT Academy for $19 a month. The link is in the description. Otherwise, I will see you guys on the next one.